Hello there, and welcome to ASCO's Journal of Oncology Practice podcast. This is Dr. Bob Miller, consultant editor at the JOP. Cancer survivorship is now recognized as an important part of the cancer care continuum, although that wasn't always the case. But we're trying now to apply the best principles of evidence-based medicine and patient-centered care. Part of that is the Survivorship Care Plan, which is a critical component. What these are written or sometimes electronic documents that incorporate a summary of treatments received during an episode of cancer care, and importantly, follow-up plans and guidelines. Survivorship care plans are the topic of an article that was in the online version of the July JOP issue entitled Patient and Provider Preferences for Survivorship Care Plans. I'm pleased to have the lead author of this paper as my guest for this podcast. Dr. Deborah Mayer is an advanced practice oncology nurse and researcher from the University of North Carolina and former president of the Oncology Nursing Society. Her current interests include e-health interventions, survivorship care, and quality cancer care. Deb, it's great to have you tonight.
Thank you very much. I'm pleased to be here.
So let me start by asking you a question in kind of a larger context. Much has been written about cancer survivorship since the 2005 Institute of Medicine report came out, and the topic is prominently featured at ASCO annual meetings and lots of other conferences. Have we reached any type of a tipping point yet in oncology practices for the adoption of survivorship care plans?
I don't think we've reached a tipping point for care plans, but I think many people are struggling in trying to figure out how to adopt the recommendations that will soon be a requirement in 2015 by the Commission on Cancer, as they are putting that in their 2015 standards of care. Mm-hmm. So I think that people are paying attention to it because it's part carrot and part stick. They know they're going to have to do it sooner or later. I think this is an example, though, of where we may have gotten a little ahead of ourselves about this actual tool that we're talking about. And it is a tool. And it's a tool that's really meant to enhance coordination of care and communication between providers and with the patient and family.
Sure. So let's talk about your paper. What was the research question your group was interested in, and how did you go about studying this issue?
The recommendation from the Institute of Medicine was not an evidence-based recommendation, but one that on face value had a lot of validity. Everybody thought this was a good idea. The question then comes to answer, what does it look like? When do you give it? How is it given? Who gives it? All the devil in the details piece of it. And so what we did was created 5 templates for a fictitious patient, an older man with colon cancer who had finished chemotherapy, and we shared it with different survivors and with primary care providers to get their feedback about them. So we created and it was with the same data. The patient was a Stage 3, 63-year-old man, et cetera, et cetera. And so they could actually compare all 5 of them. And what we did with the focus groups is we actually got them talking a little bit about what their experience was. Was anything ever written down? How did they feel about the communication between their oncologist and their provider, their primary care provider, all of those things. And then we showed them one by one each of the templates, and they asked them to critique it. Then we gave them all 5 templates back where they could have them side by side and then critique them as a group, having gone through each one individually as to what they would prefer. So we created a template that was from the Journey Forward template that's available for free online. We used the OncoLife, the University of Pennsylvania, and Livestrong collaboration version. We used American Cancer Society had a brief version. We modified the Journey Forward template to a more Chapel Hill, North Carolina specific plan, because a lot of the things that in Journey Forward are only at the national level as far as resources, et cetera. So we made a similar template, but one that was much more tailored to the patient and the geographic region. And then we did the ASCO summary. So there's a real range of summaries that they got to see, and we walk through them with each of those.
I think you said this, but these are all generally available free of charge online?
Yes, yes.
Okay. And just for the listeners, the list of these templates is in the paper. It's in the manuscript, so you can look at the website. So, and you did this with a group of survivors and a group of primary care physicians. Is that correct?
Actually, we did it with 4 focus groups of almost 30 survivors, and we really made an effort. We even had some patients with metastatic disease in them. We did not limit it to early stage because, technically when we talk about survivorship, we're talking about all patients. And in many ways, patients with advanced disease get left out a lot of these discussions. Yeah. A lot of the discussions presume we're talking about people who are ending treatment. And we had some of these patients also give us some very good feedback and what they would want for this, even with advanced disease. So we also really paid attention to getting at least some racial diversity. And we did this in one Baptist church in Durham, where the whole sample was African American men and women. So we really and we got different socioeconomic status, education levels, et cetera.
That's a great point about not limiting it to the adjuvant patient, because I think that's the concept that most of us have about care plans is, you finish your 4 cycles of AC and Taxol, and then that's the only time you use it. But
right.
It sounds like it's more than that.
Right. And so they did give us a lot of feedback about that.
Okay.
One is, I think the take-home message from the survivor's point of view is this was nice, but it was too little too late. I want the listeners to understand that there was nothing wrong. They liked some of the templates better than the others. Some of them explained things better. Some of them had wording. Some of them had layouts that they liked better. But basically, they said this would be very, very helpful. They liked it, but they wish they had gotten something like this when they were being diagnosed.
So tell me more about that. The survivors were asking for this document to be sort of a living document that was updated continuously throughout their course of treatment?
Well, they didn't ask for it in that way. And I think when we get to the technical issues, that may be difficult. But many patients do not get their treatment plans written down where they can go home and look at the words. They're told they may be on these drugs or told what their diagnosis is. But when I in my clinical practice, I see breast cancer survivors and deliver survivorship care plans. And it's amazing, a year into their treatment that they're saying, oh, that's what I have. And it's not that they don't know they have breast cancer, but to really go through again their estrogen and progesterone status or what their Oncotype DX number was and what it meant. There's a lot of fuzziness at a time when they're probably not really absorbing a whole lot. So I think they want a very simple 1 or 2 page fact sheet up front with the names and numbers or how to contact their providers, their name of their diagnosis, and what the overall treatment plan is. Most of the survivorship care plans have way too much detailed information that isn't as useful and is missing some of the information that would be more useful for the reader.
What about some of the communication issues that survivors talked about? It sounds like you uncovered some things that were some common themes.
It was very, very powerful. Everybody to a person in the focus groups could tell you when and where and how and by whom they were told their diagnosis. But they also spoke a lot about how that went and about the communication between their primary care provider or whoever diagnosed them with the oncologist or oncology team. And when it went well, the patients felt safe. They felt like their team had their back or had a safety net underneath them. And when it didn't go well, they were very upset. And often, we had patients there who would say, I'm never going back to that doctor again because of how things handled. I never heard from my primary care doctor again after I was diagnosed. For 3 months, I never heard from anybody. Mm-hmm. Where a patient would say, oh, mom called me or I saw him or whatever. And so the role of the primary care provider during that process was incredibly important, but it did not go well all the time.
I thought it was interesting how some of the patients said that it seemed like it was almost up to them to update their primary care physician about what was going on with their oncology care, which is kind of a sad commentary.
Well, we'll get into that more when we talk about the providers, but that is true. And they could always tell when they were speaking to their doctors whether they were in the loop or not. And oftentimes the providers were saying they would have to probe their patients to figure out what was going on because they may not have gotten any information to know.
I thought one thing that was very interesting, and you have a table of quotes. This is table 1 from your paper, and one of the quotes was about who do you call if you're a survivor? Which doctor do you call when you have this or that problem? And I think as an oncologist, I'm sure I sometimes forget this. Of course, call me. But the patient is often bewildered. But I love the answer. So what did I do? I used to call my nurse, and that sounds like such a common theme that I think a lot of patients will sort of default to. They have a relationship with an oncology nurse, irrespective of which practice that nurse is in, if they're in different practices. And it seems like that may be a default.
Exactly. And the other is that very few of them felt like they were continuing to be followed by their primary care provider, and they had trouble differentiating what issues to call whom for. And nobody really spent time telling them or that they recalled being told, if you have a fever, you call us or what have you. And you can see that in an example when that happens with bone marrow transplant patients with the oncologists. Do I call the transplanter or do they call the oncologist when they are starting to run a problem? And when they start getting better, do I call the oncologist or the pediatrician then if it's a child? And so there's it's not unique to this, but it's a mirror to our lack of coordinated care and our poor system of communication. And patients are in the middle of this being pulled hither and yon. And if they're an advocate enough, or if they have a family member who's an advocate enough, they may figure it out enough on their own to make it work. And then there's others who flounder and are lost.
And what did the survivors want in terms of the mode of delivery? I mean, did they have a preference, or did you ask if they had a preference for electronic versus print? And what was the timing where they wanted these plans delivered to them, if you will?
So we did ask about preferences, and everybody wants them in paper, but they would also accept it electronically, but not only electronic. The reason being they're working with a lot of different people of different ages, and they may or may not have all the computer savviness to share or access, etc. And so everybody wanted a print version. They wanted it in their hands. And, some people said, I might move. I need to be able to take this with me. It's not, getting into somebody's portal may not work for me if I've moved from 5 years from now. I mean, I know one survivor who's 40 years out from her Hodgkin's and about 30 or 25 years out from her breast cancer. And she tried to get her records. And that physician left that system, and they're in some iron mountain, and she'll never be able to access them to know exactly what doses she got of what. So I think that they want a paper version. And they said, even if it just goes home in their drawer with the other folder with the rest of their materials, they know it's there. They don't even need to or necessarily want to look at it. They just want to know it's there if they need it. And that alone is very reassuring for them. Now, in another study we did that was funded that hasn't been published yet, but we will be presenting it this summer, is we did this with colon cancer survivors, where we tracked and administered a tailored survivorship care plan, again using the Journey Forward template, in a CDC-funded study in stage 1 through 3 colon cancer, not rectal cancer, and surgery only or surgery plus chemo. And we did ask them when they wanted it. And most of them either wanted it just before treatment was ending or within the first 3 months of treatment ending.
What do survivors want to know about the risk of recurrence? What kind of recurring questions, if you will, did you hear about that topic?
They don't want to know about risk as far as numbers are concerned. They want to know what it looks like. Okay. They want to know what they should be worried about and what they don't have to worry about. So, for example, should I worry if I have a headache? Shouldn't I worry if I have a headache? Is our headache okay? They want to know what those kinds of things are and what that might mean and what would happen then. You'd call back and we'd figure out what was going on and we'd, talk to you about treatment again. They don't care as much about, you have a 33% chance it's going to come back or not. That was less meaningful than knowing what they should be worried about. How to know if their breast cancer came back on their chest. What would that look like?
So let's talk about the primary care physicians. You interviewed several doctors. Talk a little bit about who was chosen and what kind of questions did you ask them?
We were going to do focus groups with primary care providers, whether internists or family practice docs, but we could not get a group together because of time issues. So we ended up doing in-depth interviews, and I interviewed each one for about an hour, tape recorded it, and transcribed it. They too had the 5 templates in front of them. We went through them one by one. And then we went through the group. But before we started that, I did ask them the questions about their relationships with oncologists and the communication patterns that they did or didn't have. And so by the time we hit the fifth person, we were really reaching saturation. We weren't hearing very much new. And so that was very interesting, I thought.
And what kind of themes did you hear from the primary care physicians?
There are a number of issues depending on the history of the relationship between the two providers. If for some reason they trained together in the early days or they're in the same system and they know each other, the communication tended to be easier. And if they worked in a system that had electronic health records where the primary care provider could access them at any time, they didn't feel so out of the loop. If perchance they were not in a system like that or had a patient outside of that system, they may never get any acknowledgement at all. So they were really in the dark about what was going on. And they really, there was a real expression of frustration around how they were left in the dark about what was going on and what their role was. They really felt like they should have some responsibility and some role in all of this, but it was very unclear what it should be.
What type of content were the primary care physicians interested in the plans?
They thought the versions I showed them were great for patients, and they universally said it was too long for them. A Cliff Note version or a streamlined version that was no more than 2 to 3 pages that had the patient's diagnosis, the treatment received, what the surveillance plan was, but most importantly about the surveillance plan wasn't get a CEA every 3 months. It was who was going to get the CEA 3 months. Was it their job or was it the oncologist's job, or were you going to take turns? So they want to know not only what was going to be done, but whose responsibility was it going to be. And they want to know what recurrence looked like. What should they be looking out for? And they want to learn about managing or looking out for late effects or long-term effects, like if somebody was continuing to have peripheral neuropathies, that was from, their Taxol, and then that might get better over time or not. They wanted, because they're not oncologists, they don't know all this, although I'm not sure not all oncologists know all the late effects either. It's something that they want to know more about and feel that they can be helpful for, but they need to be informed about it.
I had to chuckle. One of your comments, you said that they didn't want any acronyms, so I guess that they must be used to getting reports from oncologists about MOP-ABV hybrid and ProMase-Cytobomb and, all the gobbledygook we speak in.
I'll tell you, I read some of the clinical notes of my colleagues, and I don't even understand at times. And when I actually write in English, and it takes me longer to do my notes than maybe if you did a normal dictation, but I'm writing my note for the primary care provider. We know what AC times 4 is. They don't. So I really write in a way that's telling them the story about what's going on. And this is not a question you're asking me, but one of the things that I think we could do very differently from day one, and it's probably testable, but when you get a new patient, you write the primary care provider a letter. And some people may do this, but not only saying, thank you for referring Mrs. Smith. She's been diagnosed with stage 2A breast cancer. We're going to treat her with blank, blank, blank. But it's very important for us and for Mrs. Smith that you stay involved in her care throughout, and that we really are counting on you to continue with her normal health care while we're treating her for her cancer. Then we wouldn't be getting into all these issues about sending the patient back because they've never left.
So to proactively basically reach out to the primary care docs and say, stay on board.
Their diabetes, manage their hypertension, please give them their flu shot, all of those things that matter to the patient. And we know that shared care, when they get both sets of care provision from those providers, they do better than if they don't. We have data from a number of population studies that look at that. In fact, one study that Craig Earl did looked at metastatic colon cancer patients on chemotherapy, and those who got their flu shot lived 3 months longer than those who did not. Gave them their flu shot, their primary care provider.
What further research is your group doing in the area of survivorship care planning?
We just received another grant that we're going to take this the next step further, where we're really going to try and bring oncologists and internists together to test out whether that idea about the letter up front and then getting the summary, the treatment summary at the end to say, in fact, this is what happened. We told you we're going to give you the patient X, Y, and Z, and now we're going to tell you we did that and here's what happened. And then talking about health monitoring and health promotion and being more specific, we're trying to work with Journey Forward into creating the streamlined version for the provider. And we're going to test that out and see whether that's helpful as delivered and what they're going to do with that along with the ones to the patient. So this is incremental. We're taking all of this data and moving forward now. In our CDC study, we actually tracked how long it took to complete these, patient satisfaction and primary care provider satisfaction in receiving them, because in the CDC study, we delivered them to the patient and sent them to the primary care provider. Did a follow-up 2 weeks later about it. And so, needless to say, both groups of people were very satisfied with getting them. The primary care provider said, this is nice, but make it shorter. So that was our next step. The time to see the patient is reimbursable by length of visit. So when I see somebody and I'm giving them their care plan during a transition visit, I bill for the length of time, and it can be a level 4 or level 5 visit. But what doesn't get reimbursed is the amount of time it takes to complete the care plan, the treatment summary. And there's a big gap in the informatics arena where if we could have an IT system that populated the treatment summary and then just need to be reviewed and adapted for quality assurance, that would make this process so much easier. But we're a long way from that happening. And so it's the time to accurately complete this that matters. And I also think if we streamlined it and didn't put as much detail as we have been in them, it would probably make them faster to complete as well. Needless to say, the patients who are just having surgery, it was faster to complete theirs than those who are getting chemo. Part of the time it took to complete the ones with patients on chemo is it was so hard to interpret what happened to patients over weeks or months of treatment. Did they get their dosage adjusted? Are they still on that drug? Because of the way the chemo records are separate from the notes, and the notes didn't always have the details, and the treatment wasn't summarized. So I think we have some improvements that we can do around how we document what we're doing in a way that might streamline completing a treatment summary. A number of people are limping forward trying to figure out how to do this. And I think it's going to be a while before this really is implemented for most patients most of the time. I think right now, even in NCI designated cancer centers, some of the populations get them some of the time. So I think in the next couple of years, as this standard becomes a reality, we will need to be increasing how we do it so that more patients have access and more primary care providers receive this. I think there's still a lot of bugs to work out in the process. One of the biggest things I'd like us to see is to measure some outcomes to say what difference this is making. And if it's just even a difference that patients feel more satisfied about the care and feel that their primary care provider and oncologists are communicating, that may be the best outcome we could ask for. But I think we need to keep asking those questions.
Dr. Mayer, thank you very much for taking the time to talk with me tonight about this very interesting topic.
Great. Thank you very much.
And that'll about do it for this podcast. Be sure to read this paper from Dr. Mayer and colleagues, which appears in the July Journal of Oncology Practice in the online version only. We'll be back next month with more podcasts from the September issue. Enjoy the rest of your summer. This is Dr. Bob Miller for the Journal of Oncology Practice. Thanks very much for listening.